Let's start with chronic cough. Chronic cough is common, but actually what do we mean by chronic cough? Is it cough that's more than 2 weeks, 4 weeks, 8 weeks, 12 weeks? Actually, I couldn't really find a good consensus on it, but most articles will say chronic cough is something that lasts 8 weeks or longer. Okay, so basically you can use 8 weeks as the cutoff, or 4 weeks in children. But the question would be how soon after the cough that you want to do an X-ray. So actually, when should we do an X-ray? I think that is something that a bit difficult to answer, because everything depends on clinical. So if you think clinically patient need an X-ray, then you should do an X-ray, even though it's only a week or 2 weeks or even 3 days or 4 days. That's not matter. So a bit difficult to say that you must do after certain, trying to be regimented. Only after 8 weeks you need to do an X-ray. I think that's a bit difficult. But talking about chronic cough, there are many causes. Some are common, some are less common, and only about half can be seen on X-ray. The other half we can't. I cannot see post-nasal drip. I cannot see bronchial asthma, although I've made diagnosis of bronchial asthma before on X-ray. I cannot see ACE inhibitors, for example. But if there is infection, COPD, that's bronchiectasis, that's something that I can pick up on the X-ray. And these are the things that we are going to see today. Let's look at this one. So for practical purposes, I don't want to follow the 8 weeks ruling. There were cases that let's look at this X-ray. 60-year-old girl presented with chronic cough. Whatever the history given here are actual history given by the doctor. So I'm just copying back whatever the history that was given. So 60-year-old presented with chronic cough 1 month, no associated hemoptysis or loss of weight. Anyone can pick up where the pathology is, on the right, on the left, and what do you think it is? So the X-ray is I would say a bit rotated X-ray, but then how do I know rotation? Because of the spinous process, median and clavicle, spinous process, median and clavicle. This is near, this is far, and then this side is a bit loosened, this side is a bit opaque. So I know this is because of rotation. But then you can appreciate the abnormality further up here. Can you appreciate the cavitation, consolidation with cavitation? This is consolidation, and there's a cavity inside this consolidation. So straight away, I would make a diagnosis of active TB on this one. Most TB will present with chronic cough, and some will present with hemoptysis. My question there is, what causes hemoptysis in PTB? It's quite often that we get hemoptysis in PTB, but why does it happen? There are a number of causes for this. It can be bleeding from a cavity wall. It can be because of endobronchial tuberculosis, that means the infections at the bronchial wall itself. Post-TB bronchiectasis, yes, bronchiectasis can be due to TB, and that can bleed. Aspergilloma, that means a fungal infection, or ruptured Rasmussen aneurysm. This is a special name for pseudoaneurysm of the pulmonary artery, secondary to bronchial artery involvement in PTB. And that's called Rasmussen. It's called pseudoaneurysm because it's not a true aneurysm. The true aneurysm, where all the wall will be distended, you got dilatation of the artery and all the wall will be distended. But in post-aneurysm, only the outer wall that's the distended. So the blood get collected between the adventitia here and the intima here. So the blood is here. So it's not like the true aneurysm that you see in aorta, for example. The other terminology that we use is dissecting aneurysm. Dissecting is when it goes in and blood dissect along the outer, between the adventitia and the media. That's dissecting aneurysm. TB can certainly present as a chronic cough.